Thank you, IDEC, and thank you all joining us today. I'm going to speak in continuum. I'm going to cover a specific high-risk categories and Charcots here. And why we do so? Because we need to categorize those patients specifically so we can reduce the number of primary ulceration, re-ulceration, as well as amputation. And same time, we categorize into very high risk and low risk. But the risk for ulceration is very common, and the risk for limb loss is also much there in your OPD patients. So risk factor commonly we know it's specifically a peripheral neuropathy which gives you the problem, sensory, autonomic, motor. And the risk factor for this neuropathy is always uncontrolled sugar, high triglycerides, high BMI, smoking, hypertension, and sedentary lifestyle. Again, sensory neuropathy, it's the biggest risk factor for the foot ulcers: burning, tingling, pain, needles, numbness, dead feelings, repeated stress, pressure, friction, shearing. Many factors play a major role. And autonomic neuropathy specifically it impairs skin drying. I mean, skin becomes very much dry, sweat irregulation, and leads to thick, dry, cracked skin and fissures. And motor neuropathy, where you see a loss of muscle tone and foot deformed. Then you see hammer toes, claw toes, metatarsal head become prominent, and changes in the pressure distribution. The calluses, these are basically presence of callus itself is an insensitive foot. It's highly predictive of subsequent foot ulceration. So that's a future ulcer. Breakdown of tissue happens, regular debridement required at your OPD care, and how it get relief, it's only by using insoles and modulated orthotics. And we can use preventive footwear as well. And basically callus increases the pressure at underlying tissue. Whenever you see ulcer, the building pressure is always increasing by 30%. That's callus gonna break in. And what to look, Dr. Alka already highlighted very well in examination, but still dermatological and vascular probably the inspection comes in the first, then the palpation, and palpation what she discussed about in detail. And this international group working for diabetic foot, they have given a guidance in 2015, and you to identify the foot at risk, prevent further ulcers, and give footwear, offloading things, diagnose, prognosis, give management of peripheral artery disease as well. So ultimately speak about at all stages, diagnosing early, and then educating patient and managing those complications. Again, risk, specifically patient who will have the risk, basically those who lost the protective sensation. And simple, what Dr. Alka spoke about that since Winston monoamylophen, they speak about the same, just pressing against the skin to the point of buckling. And if patient cannot feel that simple sense, and patient is at very risk. And this is very, very effective than using those BPT machines and biosthesiometer. It's very easy. And this definitely find those patients who are prone for ulceration. And all those patients, type 2 diabetes, at a time of diagnosis, they should be done this in the first OPD itself and every year. This is the risk form where we fill up every time patient walk in our cabin, and we see the ulcer. If there's no ulcer, then we try to see the callus, and then we check for all these parameters like neuropathy, foot ulcer, then other things. This is what the screening form is. And how we do that with simple neuropathy with the 10 gram monoamylophen, then you have this palpation of posterior tibialis and dorsalis pedis. Check for ulcers, callus, infection, deformity like I spoke about those loss of muscle tone which gives you deformity, the gangrene and arthropathy. Again, how you classify low risk, specifically there are no risk factor, but definitely there's a callus. The callus itself is a low risk thing. When you see the deformity or the ulcer, or critical limb ischemia, that's a moderate risk. And what is high risk? Patient already suffered ulcer, amputation, loss, and he is on renal replacement therapy, and definitely critical limb ischemia. So all these existing cases, they are very high risk. And you know what? They are at 36 times higher risk of re-ulceration. So those already patient been to diabetic foot surgeon, he's prone for 36 times more for revisits and more amputation like that. So those are very high risk patients. And this is how the cumulative risk comes in 1, 2, 3, 4. They have shown this. The one is where patient do not have neuropathy, just a zero risk. But still you need to educate the patient, annually check, and he may require diabetologist and further specialist. The grade 1 where patient already having a neuropathy, and you need to examine patient at the OPD annually. Again, tell him to use adapted shoes. Always use adapted shoes, not the branded one. And again, the caretakers is required. Grade 2 and grade A and B, where there is a deformity, there is a PAD, and where patient required to examine the foot. Sometimes he required therapeutic shoes, not always adaptive, therapeutic shoes, where the wedge kind of thing. And he required at least 6-month checkup, and he requires your care, primary care physician, your diabetologist, the foot surgeon, the podiatric, as well as shoemaker now. The shoemaker comes picture because he's not going to buy the footwear from the local shop. Okay, and grade 3 where obviously there's an ulceration, amputation, Charcots, where you require to check daily basis at the patient level, and they require it at your clinic every 3 months, quarterly, and you require a multidisciplinary approach. So again, who are at risk about ulcer, specifically male patient, commonly more male than female. Then there's a previous ulcer history, smoking, and we often say there's PAD, neuropathy, and structural changes. Already patient is having structural deformities, and again hypertensive, uncontrolled sugar, sedentary lifestyle, already skin, dry skin, and a patient having abnormal gait and abnormal patterns and when they wear the high heel shoes. Severity, again, there's another scoring given by University of Texas where they say SINBAD. SINBAD is S for site, see the site, I for ischemia, N for neuropathy, B for any infection, A for amount of area, and D is the depth when you are actually looking for a osteomyelitis. Then the simplified 60-second screen, the same thing which I spoke about. And this is IDEC foot screening chart. Again, the same low risk, high risk versus low risk, and where you start managing such cases. The problem to report, whenever a patient has a problem like cuts, fissures, calluses, breaks, he should inform you. There must be a mandatory thing. You don't manage the ulcer at your end, you need to inform me. Any changes in color, discoloration, ingrowing toenails, very common factor where ingrowing toenail they try to cut by themselves. Because that's the source of infection, bacterial infection. Again, loss of sensation. Patient may tell you casually, doctor, when I walk on the floor, I don't feel the ground. That's the first thing not to ignore. And changes in the architecture of foot, where you see, only when you see the foot, you can make out that's the Charcots. But many times patient will not show you the foot, and I will not tell you any complaints. So you need to report any change in the architecture. Clinical examination, this is covered very beautifully by Dr. Alkal, so I'm not going to go in detail of that. But commonly, since I'm talking about high risk here, the commonest thing what you see is neuroischemic foot is always a cold, a pink in color, and pulse less, and it's maybe painful as well. So this is typical neuroischemic foot what we see. And neuropathic foot where it is well perfused with bounding pulse. This is versus. Now it is a neuroischemic and neuropathic. So neuropathic is well perfused with bounding pulse. Distended dorsalis veins are very much perfused. What you see is a high arch and the claw toes. And patient will not be perceived trauma or infection. He is walking insensitive with that ulcer itself. Again, deformity, this may be result of diabetic foot neuropathy, where you lose intrinsic muscle mass and causing the toe digit to buckle as other muscles become imbalanced. What you see is the first line is hammer toe, then you claw toe, hallux valgus, the Charcot's joints. And localization of ulcers, specifically because this intrinsic loss, what you see is the ulcers are developing in this deformed foot. And the Charcot's is classical. This is classical, severe peripheral neuropathy sign. Foot deformity, the patient will have good blood supply. You see the bounding pulse is always present, and always patient will have a risk of fracture when the HbA1c is very high. This is often we try to control sugar, but patients already have a fracture now. So when he suffered a fracture when sugar was very high. This is what the chart shows about this Charcot's foot, where you look after. So prevention, ultimately you have to identify at risk. Regular inspection, as I told you, how annually, biannually, 6 monthly, quarterly, for every risk. Again, education. Education is the key here, not to the only patient, to the family as well as the primary care physician. Okay, and routine wearing of appropriate footwear, not the Dukanwala footwear or a branded one or a sports shoe or a one size bigger shoes. No, nothing like that. It's an appropriate footwear, either adapted one, made or therapeutic one after amputation what we offer them. And treatment of pre-ulcerative signs, also calluses, ingrowing toenails, you need to treat them properly. Again, look for those high areas. Which are the high areas? These are the high areas where patient will have ulcers, will have callosities, continuation of calluses growing, keep on doing debridement. Still those keep on developing because of they exposed to the shear forces. So this is what examination, we talk about symptoms, which we discuss about. Then pressure perception, we use monofilament. Vibration, we use 120 Hz tuning fork. To discriminate, we simply use pinprick. Again, without penetrating the skin, we often use a needle and try to show them that you're not supposed to use it. Dorsum of the foot always. Tactile sensation, not necessarily with the cotton, you can do only with tip of the finger also. And again, check for the reflexes, that is Achilles tendon reflexes. So sensory foot examination discussed very well in detail. So again, I will not go in detail of that, and directly this is another Harris mat, where we try to put the patient steps on the ink mat and walk on the long sheet of paper, where the footprints are analyzed for pressure point. This is really for high risk patient, not for every OPD patient I'm talking about now. When we see the callus is there, the ulcer is there, and you want to differentiate now this patient, and you are thinking about giving adaptive footwear. So you must do this Harris mat. Not every patient, but high risk patient. Again, ink pad, this is the same system they are shown here. Ankle Doppler ABI index, what you do with pressure, this is very important, severity to find out the cerebral ischemia. Again, systolic pressure at ankle, what need to do been done properly. You need to have proper cuff size, again applied properly, taken readings to be taken, and again when you have more than 60 millimeters of mercury, the limb variability is always 86%, so you don't need high profile sonology, Dopplers, and MR angiography. You can simply do at your clinic, okay? And this is what the evaluation, both sides to be done, how it is done. Then the non-compressible is more than 1.3, the normal is up to 1.3, and below, anything below 4, it is severe PED. So both sides to be done properly. And again, this stepwise approach is shown here, where you see the ABI, depending on the ABI index, and how you move ahead. Depending on the ABI, if ABI is fine, you don't need to do anything, but as ABI goes down, then you really need to do the duplex sonography, and ultimately you end up doing MR angio. Examination part she has already covered very well. I will not go in detail of that. Investigations also, evaluation. Nuclear scan, we rarely do. We've got a simple X-ray which reveals many stories. Again, X-ray is very important. X-ray is very important in specifically Charcot's foots. At presentation of hot, red, swollen foot, every 6 months you need to see the X-ray and differentiate the presenting points. And again, when you are putting patient into offloading and then giving him a shoes, and that time also you need to do X-ray. And if there's an inflammation, you need to do X-ray to differentiate between the fracture. And osteomyelitis, obviously we do X-rays to differentiate, again to see the reactivation from the osteomyelitis. So again, I'll repeat this same thing, all type 1, type 2 at a time of diagnosis annually, then categorize patient in risk category, and depending on the category, 6 months, quarterly, and again you need a multidisciplinary approach and therapeutics. So risk categories are shown here. All low risk patients, you need to check them annually again, and provide them education. That is the key here. And high risk patient, obviously patient will not do anything. You need to provide him a team apart from education. So this management part will be taken care by Alpana Sowani now. Hereby invite her, or Dr. Snehal Tanna from Thane.